Esteemed jury, dear participants, listeners, ladies and gentlemen, on behalf of the Students' Scientific Associate of Medical University of Silesia in Katowice, I would like to thank you for coming and taking part in International Medical Congress of Silesia 2024. My name is Julia Herbuś, and I have an honor of moderating. It is my pleasure to coordinate Dermatology and allergology session. I would like to cordially welcome the esteemed jury. President of the jury, Dr. Mikołaj Łanocha. And member of the jury, Dr. Anna Tekielak. We would like to explain to you the rules of the session. The order of the presentation will be the same as in the abstract book. The maximal time for presentation is 7 minutes and 3 minutes for the discussion. If the presenter exceeds the time, he or she needs to move on to the conclusions and finish the presentation as soon as possible. Esteemed jury, I would like to kindly remind you that if you are as the supervisor of the paper which is present, you should not assess the work. In that case, please cross out the number on your card. Other members of the same clinic are able to assess the presentation. I would like to remind that if the work is present in English, the discussion also should be run in English. If the commission will ask the question in Polish, the authors of the work are obligated to answer in English. We kindly ask the jury to assess scientific value, way of presenting, discussion, and own contribution. When the session ends, we kindly ask you to give the cards back to the coordinator. To begin, I think we can start with the first presentation. I would like to ask the paper Hormonal and Lipid Profile in Acne Vulgaris Patients.
Okay, could you tell me if I should share the screen or maybe you...
Yes.
Okay. So my presentation is visible for you?
Yes.
Okay. So good afternoon, honorable jury, the organization committee, and all audience. So my name is Weronika Szybek-Skora, and I'm a member of Student Scientific Society of Endocrinology in our university in Poznań. And today, ladies and gentlemen, I would like to present the effect of our work titled Hormone and Lipid Profile in Acne Vulgaris Patient. So I would like to start with a couple words about pathogenesis of acne vulgaris, which is strongly correlated with a hormonal imbalance. And most of studies confirmed the correlation between, for example, hyperandrogenemia or hyperprolactinemia and acne lesions. And hormonal imbalance affects sebaceous glands and also promotes inflammatory process, what can result in increasing the acne lesions like comedones, for example, and nextly in the scar. So the aim of our study was to evaluate serum levels of prolactin, luteinizing hormone, follicle-stimulating hormone, testosterone, high-density lipoprotein, and triglycerides in patients with acne vulgaris and compare them to the controls. 41 patients with acne vulgaris and 47 age and BMI matched controls were enrolled in the study, and levels of hormone and lipid parameters listed on previous slide were evaluated in both groups and compared using of the statistic methods. So the recruitment of participants was performed with use of strict criteria, exclusion and inclusion. And participants recruited to the control group didn't present any chronic diseases, including acne, and didn't receive any hormonal on chronic treatment. And in the study group, the inclusion criterion was presentation of acne vulgaris diagnosis. And what is important, we excluded patients with any endocrinopathies like PCOS, thyroid dysfunction, and adrenal glands dysfunction. And all inclusion and exclusion criteria are listed on this slide. And what is also important, each participant gave informed consent to be enrolled to our study. The result of physical examination of our participant are presented in this table. And as we can see, both groups were matched in weight and BMI. The laboratory examination of each hormone serum level was conducted with use of ELISA method, and lipid parameters were assessed in the central hospital laboratory. So the result in both groups were following. That statistically significant difference in the hormonal serum level were observed in testosterone, prolactin, and FSH serum level. And we also observed statistically significant difference in triglyceride serum level between both groups. So in our next step, we decided to take a look at especially two elements, prolactin and triglycerides, because the results of testosterone and gonadotropins could be affected by sex and age, the construction of our groups. And as we can see on presented figure, prolactin serum level was statistically higher in patients with acne vulgaris. And similarly, triglycerides serum level were statistically significant higher in the study group than in controls. And so our next step was comparison our results with previous study. So we choose articles with similar control and study group and compare our results with other. And as we can see, 2 by 3 articles confirmed statistically higher prolactin in acne group, but the third study difference wasn't statistically significant. And the same for the triglycerides profile. Also, 2 by 3 studies correspond with our studies, but the third one also wasn't statistically significant. So at the end of my presentation, I want to show the most important conclusion, which are the effect of our study. And the first one, the results indicated the presence of elevated prolactin serum levels in the group of patients with acne, and that this balance in lipid parameters can be correlated with hormonal imbalance, but also can have an influence on presence of acne lesions. And what, in my opinion, is the most important, our result corresponds with previous study, what could indicate the high clinical importance of hormonal and lipid profile examination in patients with acne vulgaris. Thank you very much for your attention. Also, thank you our tutor and our doctors who helped us. There are a list of our references. And thank you one more time.
Thank you so much. Now I would like to invite you all to ask questions and discuss the presented paper.
Maybe I switch off my camera to look at you.
Okay, I have a question. Did you pay attention in what phase of menstrual cycle were the hormones measured?
Yeah, it was the bad points in our study because we didn't point which one day of menstrual cycle it is. So we decided to exclude gonadotropins because they are mostly dependent from the menstrual cycle.
Okay, and what do you think, how we can use those results from the study in our daily practice? Do you think we should measure the hormone laboratory test in every patient with acne vulgaris?
I think it could be a future, but maybe not now. I think when some features could implicate some clinical features which are correlated with some endocrinopathies could be examined. But I think when we make better and better studies which show us the real correlation between hormone and acne, it will be the future to examine maybe all hormonal profile in patients with acne.
Okay, thank you.
Thank you very much.
Thank you so much. And now I would like to ask to present the paper entitled Exploring Gender and Age Disparities in Public Perception of Smoking's Influence on Skin Healthy survey study.
Okay, hello. I will share my screen right now.
Yes, we see your screen.
Okay, I hope you can see it well. Hello, my name is Ieva Nagaite. I'm a medical student from Vilnius University, and today I will present two theses that I prepared together with my colleague Viktorija Virbauskaitė. So the first thesis is Exploring Gender and Age Differences in Public Awareness of Alcohol's Effects on Skin Health, a survey study. According to the World Health Organization, nearly 23% of the world's population used tobacco in 2020, with higher rates of tobacco use among men than women. Although many of the health consequences of smoking are well known, the effects on the skin are still not well studied. Because of this, the aim of our study was to assess public perception of and knowledge about the potential impacts of smoking and skin condition. An anonymous online survey was conducted between February and March of this year. The data collected was analyzed using Microsoft Excel and IBM SPSS. Around 66% of women and almost 34% of men participated in the study. Almost 69% of the participants were under 35 years of age, while 31% were 35 years of age or older. Half of the participants reported using tobacco products. As smoking prevalence differs between the genders according to the World Health Organization, we decided to compare our results between genders as well. We found that the prevalence of smoking was significantly higher among the men in our study than among the women. This could maybe be explained by women's greater interest and awareness of the effects of smoking on the skin, which was significantly higher than that of men. It comes as no surprise that women were also more likely than men to perceive that smoking negatively affects the skin condition by more than 30% difference. Women were more likely than men to perceive that smoking negatively affects wound healing and skin diseases. As you can see in these graphs, the difference is very big. A higher proportion of men said that they don't have an opinion regarding this issue or that smoking has no effect, which is quite alarming. Women were also more likely than men to perceive that smoking promotes premature aging and increases the risk of skin cancer. You can see that the difference here is also quite significant. Women report that awareness of the effects of smoking on skin condition influences their consumption of patterns and were also more likely to consider quitting smoking. This may be linked to their greater interest than men in the effects of smoking on the skin and the perception that smoking has negative effects on the skin and the skin-related issues. Exclusively women sought services from beauty professionals for skin changes potentially caused by smoking. And that is also no surprise because usually women are more likely to take care of their skin. Due to different generational worldviews, we decided to also compare the respondents by age. Individuals who were less than 35 years old were categorized as younger group, and 35 years or older individuals were categorized as an older group. As you can see, older individuals compared to younger ones were more likely to seek services from beauty professionals for skin changes potentially caused by smoking. Younger people were more likely to think that there was a link between smoking and premature aging, and were also more likely to think smoking had a negative impact on wound healing compared to older people. Older people were more inclined to indicate uncertainty regarding smoking impact on skin diseases, but thought that smoking increases the risk of skin cancer, which is very interesting. Older people also are more likely to contact health professionals about skin changes that may be caused by smoking. And that may be due to the fact that health professionals were more likely to inform older people about the effects of smoking on the skin conditions, as you can see in these graphs on the right. The most common manifestation of smoking, and perhaps the most socially distressing, is premature aging. In the picture on the right, you can see the illustration of that. It's called smoker's face, which characteristically has prominent wrinkles, gauntness of facial features, with prominence of the underlying bony contour, and also atrophic gray appearance of skin. And the more you smoke, the more prominent these changes are. Cigarettes are known risk factors for developing allergic contact dermatitis. In cigarettes, allergens such as menthol, licorice, or formaldehyde can be found. Nicotine patches themselves can cause an allergic reaction or irritant contact dermatitis on the side of the application, with nicotine being the main allergen. Smoking, as well as independent risk factor, is for psoriasis, which is higher in men. In addition, remission of psoriasis after treatment is shorter among people who smoke. Although smokers have a significantly higher serum total immunoglobulin E level compared with non-smokers, the reports are conflicting in regards to the effects of smoking on atopic dermatitis. Smoking has been reported to be independent risk factor for hand eczema as well. However, other studies showed no association between smoking and atopic dermatitis or hand eczema. While some reports show a dose-related linear relationship between prevalence of severity of acne vulgaris and cigarette smoking, other studies reveal no association. The risk of developing rosacea is also lower among current smokers, perhaps due to the vasoconstrictive effect. Epidemiological studies demonstrate both positive and negative correlation between smoking, incidence, and aggressiveness of certain types of skin cancers. The mechanism of smoking-induced skin cancer include accelerated senescence, mutagenesis, stimulation of tumor cell growth and invasion, neovascularization, and stromal remodeling. The majority of studies have established smoking as an independent risk factor for developing cutaneous squamous cell carcinoma. Most studies have not found a clear relationship between smoking and the risk of basal cell carcinoma and also melanoma, but the evidence is quite conflicting. Smoking impairs wound healing by inhibiting the migration of fibroblasts and keratinocytes to the site of the lesion, leading to fibrosis and slower epithelialization. In addition, smoking reduces the supply of well-oxygenated blood to the skin, thereby disrupting essential metabolic processes for effective wound healing. So our conclusion is that the majority of respondents believe that information provided by healthcare professionals could encourage the public to reduce smoking, and that is an essential call for comprehensive education regarding the impact of smoking on skin health. So this will be okay. Thank you for your attention.
Thank you so much. So now I would like to invite to discussion to the present paper.
Okay, so thank you for your presentation. I would like to ask what implications for education and prevention interventions result from your observation, in your opinion?
Yeah, so I think, first of all, that a lot of people just know basic stuff about smoking that is just bad for your skin, but don't know what exactly it can cause, like cancer and certain illnesses. And a lot of people who have certain diseases like psoriasis don't even think that smoking really affects them. So I think maybe we should target people who have already these illnesses and see that smoking does affect those illnesses and maybe can affect how the treatment is going. And also we should target maybe a general population, just in general, about more about smoking on skin, because usually people associate smoking with lung cancer or other type of cancers and kind of ignore skin or just think it maybe creates superficial damage, but not something like cancer.
Okay, thank you.
I also have a question. I'm interested. Do you have so many smokers? It's 50% of smokers in the study. Is it that popular in your country?
It just so happened that this study was done online, so I think that might be the reason why a lot of people answered that they were smokers. But yeah, I think smoking is actually quite popular. The same with alcohol consumption, so it is definitely a big issue. But I think 50% would maybe be because the survey participants were more likely to smoke, I guess.
Okay, and do you know any statistic in your country how much smokers there
For
are?
smokers, I actually didn't really look into it. I think it's less than 50%, but I think at least 40% definitely. Because I know that it's definitely a very big issue and people now talk about the effects of smoking, especially with electronic cigarettes now being super popular. And a lot of people don't really consider them normal cigarettes and just don't think they are that bad.
Okay, thank you.
Okay, thank you so much. Now I would like to ask to present the paper entitled Exploring Gender and Age Difference in Public Awareness of Alcohol's Effect on Skin Health Survey Study.
I hope you can see it. So I
Yes,
will present another thesis that I wrote together with the same colleague, Victoria Verboskita, exploring gender and age differences in public awareness of alcohol's effects on skin health, a survey study. Of the 10 countries with the highest alcohol consumption worldwide, 9 are in the European Union. Even though Lithuania has dropped from 3rd place to 10th place worldwide in terms of annual alcohol consumption as of 2019, given the significant global impact of alcohol consumption, it becomes crucial to understand public awareness of its effects on skin health. Because of that, the aim of our thesis was to assess public attitudes and knowledge about the potential impact of alcohol consumption and skin conditions. An anonymous survey online was conducted between February and March this year. Data was analyzed using Microsoft Excel and IBM SPSS. Around 63% of women and almost 37% of men participated in the study. Almost 63% of the participants were under 35 years of age, while around 37% were 35 years of age and older. Half of the participants reported using more than half of the respondents, so about 75% of all respondents have been consuming alcohol. When it comes to awareness, around 84% of the respondents report drinking alcoholic beverages. It was found that almost 75% of all respondents believe that alcohol consumption has a negative impact on skin condition. However, almost 79% of the respondents have never been interested how exactly alcohol consumption affects skin condition. Around half of the respondents think that alcohol consumption has a negative impact on wound healing, and 2/3 think that it has negative impact on skin diseases. 45% of respondents who drink alcohol reported having at least one chronic skin disease, the most common being psoriasis, acne, rosacea, and atopic dermatitis. The majority of them also thought that alcohol consumption has negative impact on their disease, causing more frequent and severe flare-ups and reduced treatment effect. Around a quarter of respondents who drink alcohol said that they have noticed changes in their skin that they attribute to alcohol consumption. Dryness of the skin and lips, changes in the skin color, and loss of elasticity of the face were the most commonly reported skin changes. Around 64% of the respondents believe that premature skin aging is linked to alcohol consumption. However, only around 37% of respondents indicated that they believe that drinkers have a high risk of developing skin cancer. 7 responders, and all of them were drinkers, answered that they had been diagnosed with a skin cancer before, but they couldn't really specify which type. Only about 17% of all respondents have been informed by a healthcare professional about the effects of alcohol consumption on the skin specifically, at least once in their lifetime. Sadly, more than half of the people who consume alcohol indicated that knowledge of negative effects of alcohol on the skin does not influence their drinking habits. However, 62% of the respondents thought that detailed information provided by a healthcare professional could have a positive effect on other people and could promote other people to stop drinking, while 1/3 of respondents didn't think that it would have any impact. Awareness by gender. Women were more likely than men to believe that alcohol consumption has a negative effect on skin condition. They were also more likely to be concerned about the effects of alcohol on the skin. Women were also more likely than men to believe that alcohol consumption negatively affects wound healing and also skin diseases. Women were also more likely than men to believe that alcohol consumption promotes premature aging and increases the risk of skin cancer. There was no statistically significant difference between genders in seeking medical attention for skin lesions, possibly caused by alcohol, but only women frequently visit beauty salons in order to repair damage that was possibly caused by alcohol consumption. Awareness by age. Older people were more likely to contact health and beauty professionals about possible alcohol-induced skin changes. Younger responders indicated that they would not consider stopping drinking alcohol because of its potential negative effects on the skin. Older people were more likely to report that they would stop drinking, but for other reasons, not for skin conditions or skin health. Indirect effects of alcohol on the skin can include dehydration, vitamin and mineral deficiencies, hormonal imbalances, liver dysfunction, inflammatory processes, and sleep disturbances. Skin changes due to liver dysfunction include palmar erythema, jaundice, hyperpigmentation, pruritus, and nail changes. Late onset porphyria, one of the skin, characterized by increased photosensitivity, skin fragility, blistering, erosion, scleroderma, hypertrichosis in sun-exposed areas. Alcohol is the most common cause of this illness, type 1, specifically porphyria, in certain individuals, and is associated with chronic liver diseases. Alcohol increases the risk of liver, pancreatic, breast, oral skin cancers, so squamous cell carcinoma, basal cell carcinoma, and melanoma. And high alcohol consumption is a new risk factor for psoriasis. Heavy drinkers tend to have more treatments resistant psoriasis, including erythrodermic psoriasis. Some medications used to treat psoriasis are contraindicated when alcohol is used, like, for instance, methotrexate. Alcohol causes dilatation of blood vessels and facial flushing in people with rosacea. Seborrheic dermatitis and discoid dermatitis are also more common in people who use alcohol. Skin infections are more common in patients who abuse alcohol. Urticaria can occur as an allergic reaction or as a result of cholinergic reaction when using alcohol. So our conclusion is that alcohol consumption can affect skin health, yet perception of its effects vary among individuals influenced by factors such as gender and age. Understanding these variations is crucial for promoting healthier lifestyle choices. These are our references, and thank you for your attention.
Thank you very much. I invite you to discussion.
What do you think? What strategies can be effective in raising public awareness of the effects of alcohol on skin health, especially among younger age group?
So I think among a younger age group, we could maybe use social media. Right now, when it comes to alcohol and drug use in general, we have a lot of influencers promoting they are doing these sessions together with hospitals and promoting information about drug and alcohol and how it's bad for young people. So maybe we could involve some people that younger people to look up to and maybe involve them in these specific presentations, and that way we could maybe help to specifically target younger people.
Okay, thank you for your opinion.
Thank you.
Thank you so much. And I would like to ask to present the next paper entitled Atopic Dermatitis or maybe something more.
Good evening. Good afternoon, ladies and
Okay, sorry. So good afternoon, ladies and gentlemen. My name is Anna Schlik, and today I have such a great pleasure to present to you this presentation about atopic dermatitis or maybe something more. It was created based on our retrospective research. So let's start simply. What is atopic dermatitis? It's a chronic, complex, inflammatory skin disease that occurs mostly in children, but also can affect adults. Patients with atopic dermatitis may be associated with other diseases, and the frequency of them can have an impact of the patient's overall health pictures. So the better understanding of these correlations can be helpful for us to find the right treatment. So what was the aim of our study? We want to check the relationships between atopic dermatitis and psoriasis compared to healthy patients. Speaking of them, what was our research group? It was a group of patients over 18 years old, recruited using medical database in our clinic and hospital wards. Firstly, it was 378 patients selected by analyzing ICD codes for atopic dermatitis, other atopic dermatosis, and unclassified atopic dermatosis. In the end, 231 patients met that criteria, and 104 women and 127 men were in that group in age range of 80 to 62. What was our compassion group? It was 351 patients in age range of 80 to 72 years old, also selected by analyzing ICD-10 codes, but for other dermatoses different than atopic dermatitis. Our control group contained 291 patients with any of this disease. What was our method? We used one of the objective statistical method called the cluster analysis to find the coexistence of the lifestyle diseases, including cancers, in patients with atopic dermatitis, other dermatoses, and without any of them. We took into consideration 11 parameters, for example, BMI, diabetes type 2, asthma, and atherosclerosis. As you can see, it's working. Okay. Patients with atopic dermatitis, there is significantly less, the occurrence was significantly less in obesity and atherosclerosis compared to other diseases. However, in diabetes type 2 and asthma, you can see that there were significantly less, significantly more often, our patients have that significantly more often than patients with other dermatoses or without any of them. In percentage of selected chronic diseases, there were no significantly differences between each of the group. What about the cancers? The distribution of the cancers in the most popular cancers in our study group did not differ. Most of them were dominated by lung, colon, prostate, and breast cancer. And let's go to our final results. As you can see, there's such a massive number of numbers. The most important of them are in cluster 1 and cluster 5. But if you let me, I will go to the next slide, which is not that precise, but easier to look at. And there you can see the blue one stands for the atopic dermatitis, the orange for the other diseases. And as you can see in cluster 1 and cluster 5, the concentration of patients with atopic dermatitis have a higher occurrence. Also, in these two clusters, the occurrence of other diseases were significantly less often, especially incidence of the cancers and diabetes type 2. However, in these two clusters, there were significantly more often correlation with asthma in both of these clusters, and the depression and Hashimoto disease in cluster 5. So to conclude, in our study, we observed that in some patients with atopic dermatitis, the coexistence of other diseases were often associated with depression, Hashimoto, and hyperlipidemia. In addition, we also observed that patients can have a coexistence with other diseases such as depression, osteoporosis, multimorbidities, asthma, and allergic rhinitis, but it requires closer examination in the future. And that was all for me. Thank you very much for your attention, and I'm happy to answer your questions.
Okay, I would ask a question. In your research, the atopic dermatitis group has less frequently obesity, atherosclerosis, hypertension. How you can explain it, that results?
Relatively young group, because the group of older patients was very small, because przepraszam, because the group of the older patients stayed for the smaller group, and that's why the obesity and other arterial diseases did not occur that much. But that's really important, so maybe we'll check it because we have a plan for doing more of the research for this kind of research.
Okay, and did you look for literature on PubMed or something?
Yes.
About researches on comorbidities in atopic dermatitis?
Yes, we look into the researchers. This was one of my jobs in this research, and there were some the publication about atopic dermatitis and some arterial diseases and some depression, like in our study, there were some existence of it, and also with asthma, but they were not that popular. So we want to check it in our study, and like I said, we want to check it in the future more.
Okay, and your study was similar in results with other studies in PubMed?
Our study?
Yeah, your study with other studies about this topic.
Kind of, because our study was similar in depression, but the arteriosclerosis did not occur that often in other studies. So the depression and maybe Hashimoto in some way, but the arteriosclerosis was some new topic in that.
Okay, thank you.
Thank you very much.
Thank you so much. Now please. Okay, sorry. I would like to ask to present the paper. Can social media encourage young Polish adults to visit a dermatologist? Thank you.
Okay, so good afternoon, everyone. My name is Zuzanna Pawlus. I am from Medical University of Silesia in Katowice, and today I want to present my original study, Can Social Media Encourage Young Polish Adults to Visit a Dermatologist? Social media play an important role in contemporary world, influencing all areas of life, including dermatology, as people are often extracting medical knowledge from social media. And the objective of this study was to evaluate if young Polish adults follow dermatology content on social media, which platforms they find the most interesting, and to assess if social media can encourage them to visit a healthcare professional. Online questionnaires were distributed from January to March 2024 among young adult people from Poland. 356 respondents took part in our study, and the collected data were analyzed using descriptive and analytical statistics, and the significance of differences was tested using chi-square tests. And let's move to epidemiological data. Most of the respondents were women, 78%. Minimum age of respondents was 18, maximum was 35, and median age was 23. Most people were living in big cities. Most of them were students at the university. And most of them had educational background related to medicine. And let's move to the results of our study. 19% of respondents don't follow social dermatology content on social media at all. 38% of respondents said that they follow it. And the vast majority, 43%, don't follow social media dermatology content on social media, but when it pops up, they read it. And people in college and with higher education usually follow dermatology content. Women tend to follow content related to dermatology more than men. And the majority of men are not interested in anything related to dermatology. We also observed that people with medical education follow dermatology content on social media more than the others. The most commonly used platform is Instagram, but people also tend to use YouTube, TikTok, Facebook, internet forum, blogs, and the others like Pinterest or Twitter. People who don't follow dermatological content on social media said that they are not interested in or they don't have any skin problems. And some say that it's not their priority, that they don't have enough time, that they visit a dermatologist when they need some help instead of searching on their own, or they can't find anything interesting. Only 27% of respondents have ever asked for skincare advice, and women are much more likely to ask for advice. 77% of respondents consider competencies of influencers. The most interesting content is skincare and skin diseases, and the other interesting topics are trichology, aesthetic medicine, dermatology content encouraged 44% of people to visit a dermatologist, and most of them were women and people from big cities. The most popular reason to visit a dermatologist was to improve the overall appearance of one's skin. Dermatological examination revealed skin disease in 34% of respondents, with consistency with social media suggestion in 56%. The most popular diagnosed diseases were acne, atopic dermatitis, and psoriasis. And people who went to dermatologist and whose disease wasn't accordant with social media suggestion usually didn't have any skin disease. They had acne or atopic dermatitis. Social media usually doesn't have a significant impact on the choice of particular dermatologist. Only 19% admitted it. 34% of respondents made their family members to visit a dermatologist. And we also observed that people who have been encouraged to visit a dermatologist are much more likely to encourage their family members to visit a dermatologist. And most of people believe that social media may have a positive impact on visiting a dermatologist. And the most important results of our study are that 81% of young Polish adults read dermatology-related content on social media. The main areas of interest are skincare and skin diseases. Almost half of the respondents, social media encouraged to visit a dermatologist, with 56% consistency of diagnosis made by a healthcare professional and social media user. Dermatological content is most often viewed by women and people with higher education or during studies and medical education. The most popular platform is Instagram, and most people believe that social media has a positive impact on visiting a dermatologist. And thank you for your attention.
Okay, I want to ask you a question about what are the possible benefits and drawbacks of obtaining dermatological information from social media?
Thank you for your question. So, if people get to know some information from influencers on social media, they would go to dermatologist, and it may increase the awareness, for example, of skin diseases. So it may be good for the patient's health.
Okay, and do you see any dangers in obtaining information from the internet and social media?
Yes, I see it because not every influencer has competencies to pass the knowledge. And sometimes it may be difficult to for the patients to know which information are true or false. So it may be dangerous.
Okay, and the most popular social media was Instagram.
Mm-hmm.
And what do you think, which platform is the best source of obtaining information?
The best source may be internet forums, because information published in forums are checked by specialists, and on the Instagram everyone can publish anything. So maybe it's not the best source of information, but the most people use Instagram.
Okay, thank you.
Okay, thank you.
Okay, so can I have one more question?
Yes, of course.
Okay, so according to Dr. Wanocha's questions, I would like to ask what main conclusions can be drawn from the results regarding the influence of this content on the decision to visit a dermatologist. What do you think?
Can you repeat the question?
What main conclusions can be drawn from the results regarding the influence of this content on the decision of visit dermatologist?
Because the main conclusion of this study is that social media has an impact on patients to visit a dermatologist, and if doctors if doctors serve some informations on social media, they may encourage their patients to go to the doctor, and it may be good for the patients because maybe they don't know that they should control their skin changes or take care of the skin, and social media enables it.
Okay, thank you.
Thank you.
Thank you. Now I place Naemka Mgbedo. Please check the email. You are in the bed session. We sent you a new link to the dietetic session. So I would like to ask to present the paper entitled Role of Allergy in Atopic Dermatitis, Variability in Clinical Phenotypes of among Polish Pediatric Patients.
Hello everyone, can you hear me?
Yes, we are.
Okay. Okay, and can you see my presentation?
Yes, we see.
Okay, so good afternoon, honorable jury and dear audience. My name is Joanna Zygadło, and today I'm going to talk about the role of allergy in atopic dermatitis and clinical phenotypes among Polish pediatric patients. So, atopic dermatitis is a prevalent chronic inflammatory skin condition that affects up to 20% of the children globally and presents heterogeneously, not only in clinical manifestations, but also in immune and genetic determinants. And detailed endophenotyping is crucial to understand the disease mechanisms and associations with atopic comorbidities, as now we are entering the era of more personalized medicine. Our study focuses on diverse clinical phenotypes of atopic dermatitis as influenced by, firstly, a patient's age, so infantile AD, childhood AD, AD in adolescents and adults, and AD in the elderly. Age of onset, we had 3 groups of patients, and very early onset was until 6 months of age, then the early onset and late onset when atopic dermatitis started more than 2 years of age. And disease severity measured by POEM scale, patient-oriented HMO measure tool, and we divided it into mild, moderate, severe, and very severe atopic dermatitis. Our objectives were to characterize atopic dermatitis phenotypes and also to identify common allergic sensitizations. And by doing this, we could correlate the relationship between these phenotypes and sensitization patterns to specific allergens. Our group was calculated to be at least 350 participants, and we outperformed it. We collected data through 435 questionnaires that were administered to legal guardians, parents of children with atopic dermatitis in the hospital. As I said, atopic dermatitis severity was assessed using patient-oriented HMO measure tool, and this study investigated various factors, not all included in this presentation due to time restrictions, so also infancy exposures, allergies, comorbidities, and family history. Now quickly about our cohort. Our study included a slightly higher percentage of males, nearly 60%, with median age of 3 years. And a significant finding was that 67% of the children developed atopic dermatitis within first 6 months of life, which indicates this very early onset pattern. The age of onset distribution is as on this slide, and the smallest group was above 2 years of age. Our results showed also a varied severity distribution with 35 clear and almost clear atopic dermatitis and only 6.5% of severe atopic dermatitis. Significantly, 90% of the children with atopic dermatitis were sensitized to at least one allergen. Food allergens were most common, and in food allergens, the most common were hen's egg, bovine milk, and peanut allergy. While in aeroallergens, it was birch pollen and house dust mites. And now the very important result. While the food sensitizations were statistically more common in children younger than 6 years of age, the aeroallergen sensitizations were statistically more common in children older than 6 years of age. Now we are talking about this current age of onset phenotype. And now the phenotype based on the age of atopic dermatitis onset. And when atopic dermatitis started more than 2 years of age, so this late onset of atopic dermatitis, children were mostly sensitized only to aeroallergens. And now the distribution of different allergic comorbidities, and food allergy was more prevalent in younger age of onset group, while allergic rhinitis was statistically more prevalent in the oldest age of onset group. Our analysis also revealed a heightened risk for asthma among more sensitized individuals. What is more, when it comes to viral infections, such as molluscum contagiosum or Echema herpeticum, it was more common in children sensitized only to one group of allergens, food or aerial ones. To conclude, our study highlights the need for early detection of atopic dermatitis phenotypes to early identify probable allergies and comorbidities, such as asthma, and prevent complications effectively. This exposure may mitigate the development and severity of atopic dermatitis. And here are some limitations of our study. It is a sample representation bias because the self-reporting by parents may be in our study. The cross-sectional design that provides a snapshot at a single point in time, limited external validity, as the findings may not apply to other populations, and environmental differences. Thank you for your attention.
Okay, so thank you for your presentation. I would like to ask why was a scale such as a poem was chosen by you to assess the severity of atopic dermatitis?
Because it was a survey study, and we asked these legal parents of children about the questions that are in the poem scale. And by doing this, then we counted the points in poem. Okay. It is patient-oriented, So it is more into patients' way of looking at atopic dermatitis and not the doctors.
Okay, thank you.
I have a question. Can you say a bit more about collecting data from the caregivers, about how you collect questionnaires? It was or it was just in the hospital?
Yeah, so we had a questionnaire that was distributed by a link or QR code, and mostly it was for patients that were in the department of pediatric pneumology and allergy, and also parents of other children that were hospitalized due to different diseases, but were asked if maybe you have children with atopic dermatitis, and they said yes. We gave them the link to the survey to complete.
Okay, thank you.
Thank you so much. And I would just like to add that in the context of this work, there was an error in the book of abstract. Co-authors were actually the supervisor of the work. This will be correct in the system. And now, I would like to ask to present the paper entitled From Taboo to Trend, Aesthetic Medicine Preference.
Okay, so dear Commission, esteemed colleagues, my name is Maria Bendykowska and I'm fifth year medical student. So today I will unveil From Taboo to Trend, Aesthetic Medicine Preferences. So exploring the realm of medicine isn't just about staying current, it's about navigating the future with informed choices. And in an era of rapid urbanization, understanding these preferences is essential. So the pivotal question of my presentation is what's the prevailing attitude towards aesthetic medicine in 2024, embrace or eschew? So before we delve into the topic, let's take a moment for introspection. Would you consider undergoing aesthetic medicine treatments by yourself, or maybe you have already done that? And what role does aesthetic medicine plays in our lives and lives of our patients? And are we influenced by societal pressures or personal desires when considering these treatments? So the aim of our study was to examine the considerable variances in understanding and encounters concerning aesthetic medicine treatments among diverse communities. So the study group comprised 194 individuals with a predominantly female respondents, averaging 33 years old. And we have made self-administered Google Forms survey. And we have used Statistica software with p-value smaller than 0.01 to make statistical analysis. So 30.93% of respondents have a direct experience with aesthetic medicine. And we divided our respondents into two groups. The first one comprised 137 individuals, which were living in villages and towns with a population up to 500,000. And 36 of them have used aesthetic medicine. And group 2 has 57 individuals, which are living in places greater than 500,000 people. And 24 of them have used aesthetic medicine. So now let's jump into results, group comparison. So residents of smaller agglomerations tend to have children more frequently. They also typically achieved a higher education level or postgraduate qualifications. They were also most often employed under permanent contracts with no differences between unemployed or self-employed. And when it comes to earnings, they more frequently earn salaries within the national average range, although less often than individuals from group 2, above 10,000 zlotych per month. So experience. Individuals from group 1 were more inclined to opt for one-time procedure, whereas those in group 2 tended to engage more frequently. Furthermore, most commonly, patients undergo these treatments 1 to 2 times per year. And does the season matter? Yes, and there are noticeable differences. So residents of larger cities with population over 500,000 tend to undergo procedures more willingly than people from group 2, and they prefer autumn. Opinions. So in none of these categories, young individuals, both men and women, and undergoing these procedures for aesthetic purposes, opinions statistically did not differ between the groups. What's the sweet spot age-wise for diving into these treatments? So people from bigger cities mostly thought that these procedures could start before 30, while those from smaller towns strongly advocated for starting them after the age of 30. Quite a contrast, right? Okay, and the last one, aspirations for the future. So group 2 is more inclined to opt for these procedures in later stages of life. And this is probably my favorite question. How would this scenario change if the procedure were provided at no cost? So imagine that we have two situations. People can make for free the procedure in aesthetic medicine studio with a qualified doctor. And the second one, the procedure for free is proceeded by people without strictly medical education. So for example, someone after the courses. Surprisingly, in both cases, group 1 would be more willingly to opt for a free procedure. Furthermore, what's more is that a significantly higher percent opted for the procedure performed by non-medical. So, thoughts, better educated group 1 shows a higher preferences for non-professional services, risking then the safety of the procedure. So these findings highlight the varying perception and behaviors towards aesthetic medicine across different demographic groups, understanding the need for targeting intervention to address the complexities effectively. And these disparities may be related to varying lifestyles, preferences, or incomes. So at the end, I would like to quote to one painting, The Son of Man by Ren Magritte. And I think this can highlight individual beauty ideals and the mystery of identity, much like today's aesthetic medicine, which allows to craft our appearance according to these ideals. Thank you for your attention. Do you have any questions?
Do you have any explanation about differences in both groups in using aesthetic medicine according to season?
Yes, I think that's also about the healing process, because sometimes we have, after the aesthetic medicine procedures, have more time to heal. So, for example, people want to make it in the winter, and also where there is no UV emission, for example, or when they have a free time without work.
It's true, but what about differences that one group is more likely to one season and the other group about another one?
Okay.
Because the factors are from the both groups, and there are some disparities.
Yeah, I think that's connected to the work. Because the group 2 that is living in places above 500,000 people, so probably they are working more, and when it comes to Atom, probably they are taking more free time because there is also no UV emission. So I think that these factors are correlated.
Okay, it can be some explanation. Thank you.
Yeah, but I think there is also more place to research that.
Yeah, that's right. Thank you.
Thank you.
Thank you very much. Now I would like ask to the last present the paper Untitled, Can ChatGPT 3.5 pass the Polish specialization exam in the dermatology?
Honorable jury, dear audience, today it is my pleasure to present to you my scientific paper, which is named Can ChatGPT 3.5 pass the Polish specialization exam in dermatology? A research investigation into artificial intelligence. Okay, so when it comes to the introduction, in the 21st century's era of rapid technological advancement, ChatGPT 3.5, an artificial intelligence language model, is scrutinized for its application in dermatology. Using 118 questions from the National Specialist Examination, we assess ChatGPT 3.5's performance, comparing it to human skills and addressing ethical implications. When it comes to the objective, our primary objective is to evaluate ChatGPT 3.5's proficiency in responding to 118 dermatology questions from the previously mentioned exam. The study emphasized ethical considerations and compared the model's knowledge and skills to those of human dermatologists, what was of high importance for us and may seem somehow incomparable, but we luckily managed to do so. When it comes to the methodology, utilizing the 2023 PEE's question database, questions were categorized by Bloom's taxonomy and thematic content. ChatGPT 3.5 version August 3rd, 2023 answered 118 questions in 5 sessions, allowing us for a probabilistic evaluation. Statistical analysis conducted using RStudio assessed correctness, confidence, and difficulty. Results. The number of correct answers provided by ChatGPT was 59 out of 119 points, what gave us a score of 49.58%. And the performance was assessed for different types of questions and their subtypes. You can notice in the table number 1 the correct and incorrect answers provided by ChatGPT. In the table number 2, the division into memory questions and comprehension and critical thinking questions. Here you can notice a slight difference when it comes to the comprehension and critical thinking questions ChatGPT scored slightly better than in memory questions, what can be quite astonishing because we didn't expect some such answers. And when it comes to the table number 3, you can see the division into subtypes, medical procedures, clinical proceedings, diagnostic medication related to diseases. And you can also see the comparison. The scores are extremely different, especially when it comes to the clinical proceedings. The score is very, very low, what can also disappoint us when it comes to the future of dermatology and artificial intelligence. But we can also hope for the future when it comes to the related to diseases questions with the score of 50% correctness. And the second part of the results show us figure 1 is the comparison of certainty index between questions according correctness and incorrectness by ChatGPT. In the table number 4, you can see the comparison of the difficulty index between question subtypes. As you can probably see, they are not correlated. I will relate to that later. And in the table number 5, you can see the comparison of the confidence index between question subtypes. So as previously, medical procedures, clinical proceedings, diagnostic, medication, and related to diseases. As you can also notice here, they don't vary much. So we can also see that they're not correlated. And jumping up to conclusions, the article presents us a study that responded to questions from the state specialization exam. And we can see that the correct answer rate of 49.58% is below the 60% threshold required to pass the exam. In questions correctly answered by the artificial intelligence, the difficulty index did not significantly differ and did not correlate with the confidence index. And the second part of the conclusions, further research into the utilization of artificial intelligence in dermatology is essential, considering the improvement of model results and technical solutions. Effectively integrating these technologies later in medical practice is necessary to minimize errors and enhance the quality of healthcare in the field of dermatology. So the most important question is, can ChatGPT replace a dermatologist? Definitely not, but we can hope that in the future it will be a very helpful tool in daily practice in the life of dermatologists. Here are the references, and thank you for your attention.
Okay, so first question, why ChatGPT 3.5, not 4 version?
Because when we started the research, there wasn't the version 4 available.
And what do you think, what are the possible factors that the artificial intelligence has only 50% of right questions, answers?
Unfortunately, the artificial intelligence doesn't have the access to all the tools because some tools are restricted for it, and that's why it can't gain much knowledge for most of the questions when it comes to the exam. Yeah, because it doesn't have access, for instance, to the database with the questions or to some research papers. Sometimes it really can't analyze this data. So that's why it has a lack of its database, I think.
Okay. So thank you.
Thank you very much. All the submitted papers have been presented. We congratulate all of presenting authors and participants of the dermatology and allergology session. Esteemed jury, thank you very much for all questions and scientific words. Thank you so much. We would like to cordially invite you for the decoration and the closing ceremony of the SIMC 2024 conference which will be held in Theatre Rialto on the 27th of May at 6 p.m. On the behalf of Student Scientific Associate, I would like to thank you all for participation in this session. Thank you so much.